topic I'm going to be discussing today is atrial fibrillation in athletes. Alright, so atrial fibrillation is categorized as an irregular or uncoordinated heart rhythm. It's the most common type of atrial fibrillation that's seen, and there are 2.5 million cases in the U.S. It's most commonly seen in endurance athletes, and it's also seen in a higher percentage of athletes than in the general population. Most people say it's about 2 times more common in athletes than in the general population. There are several theories as to why athletes show it at such a high percent, but they haven't come to a definitive reason as to why. Like I said, atrial fibrillation is caused by disorganized electrical impulses in the heart. So you can see the one on the right is a normal heart. The electrical signal starts at the SA node, and it travels down the conduction pathway. And the one on the left is a heart with atrial fibrillation, and you can see all the little yellow marks are the electrical signals that are throwing off the heart's rhythm. And it's also associated with a rapid heart rate. This is because the heart's beating uncoordinated, and it has to beat faster to keep up with the demand. It's just not beating as efficiently. It's also associated with several other conditions. That's more common with the general population as opposed to athletes. It'll be things like atherosclerosis, high blood pressure, coronary artery disease, things like that. And there's also a strong genetic component too. So a lot of times you'll see it in families. It doesn't mean that you have to have it if your parents have it, but it's very commonly. Alright, and the symptoms are lightheadedness, dizziness, shortness of breath, fatigue, chest pains, and palpitations. The symptoms that are seen in athletes in the general population are the same, which is somewhat significant because almost all the other factors are drastically different. And the risk factors, namely our age, family history, smoking, high blood pressure, obesity, alcohol use, and drug use. Athletes usually don't have those risk factors apart from age and family history. Athletes usually tend not to smoke, drink, do drugs, or they don't have high blood pressure, they're not obese, things like that. And the profile for athletes is usually seen in tall, male, middle-aged endurance athletes. And like I said, it's not really known why. There's a few theories that we'll go into later, but it's still a topic that needs to be researched. And the causes. Causes usually seen in the general population are it's associated with conditions like hypertension, heart attack, congenital defect, coronary artery disease, heart valve abnormalities, metabolic imbalance, lung disease, and sleep apnea. Athletes usually present with what's called lone atrial fibrillation, which means that they have the condition on its own and it's not associated with some other condition. And one of the main theories as to why athletes get it is the first one's atrial stretch, which is when the athlete's exercising, the heart has to pump really hard to deliver all the blood that it needs to perform. So the atrial will stretch to accommodate more blood, and this stretch will cause damage to the cells, which eventually is going to cause those disorganized electrical signals. The other theory is inflammation from overtraining. So when the athlete overtrains, the body starts to break down, and you'll see inflammation. And when there's inflammation at the heart, it'll damage those cells, once again causing the disorganized electrical signals. But there is no consensus why. A lot of papers look at how often it's seen in athletes, and they present theories as to why, but they're not haven't actually tested the theories that well. Right, it's classified into one of 4 categories. The first one is first detection. That just means you have one diagnosed case. The next one's paroxysmal, which means the condition's recurring, but it subsides within less than 7 days. The next one's persistent, which is also recurring, but it takes longer than 7 days to stop. And the last one is permanent, which means it's continuous. You're consistently experiencing atrial fibrillation rather than it coming and going. And paroxysmal is the one you see most in athletes. It's not nearly as severe as the other ones. It's usually it'll come on if there's something that triggers it. It'll come on, and within a short period of time, it'll subside. And the effects, and these are effects kind of specific towards athletes. Usually you'll see a 25% drop in cardiac output when you're experiencing atrial fibrillation. And this is significant for athletes because it's seen mostly in endurance athletes, and those athletes, their cardiac output is directly relates to their performance. You'll also see increased fatigue, and this is going to cause them to not be able to train as efficiently. And the last one is people with atrial fibrillation are at 5 times greater risk for stroke. This is more of a concern for the general population. Athletes aren't as high a risk as the general population because they're usually in much better shape. They don't have those other conditions that go along with it. But it's still something that they take into account, kind of just going throughout their lives, not just their athletic careers. In diagnosis, it can be detected from simply taking a pulse. You'll notice that irregular heartbeat, but it's primarily done through EKG, especially with athletes do it during exercise testing, especially to see how they react to exercise, to see when it's going to come on, kind of like what intensity, things like that. And you can see on the right, that's the normal heart, the normal EKG. And on the left is the heart with atrial fibrillation. In the picture, you can see kind of the electrical signals that are occurring in both atria. And you can see how the wave is sort of disorganized and the beats are happening at irregular intervals. In treatment, when you're treating it, you have to consider 3 different categories: rate control, rhythm control, and stroke risk. So there's various drugs for rate control and rhythm control, which are usually taken together. Athletes sometimes they'll stay away from the rate control drugs because of the fact that they tend to have a lower resting heart rate than the general population, and kind of lowering that any further is going to put them in kind of in a dangerous level. And for stroke risk, most of the time they'll take anticoagulants. Once again, like I said, athletes aren't at higher risk for stroke than the general population, so they won't always be prescribed those drugs. The other way they treat it is a cardioversion, which uses an electrical signal to kind of restart the normal rhythm. There's also surgical interventions. First one's catheter ablation, which they feed a catheter through an artery into the heart, and they use that to kind of shut off those cells that are causing the arrhythmia. This one is the one that they'll tend to use with athletes. It's less invasive and it has a higher, pretty high success rate. There is also surgical ablation where they'll go in and remove the cells that are causing the arrhythmia. That one's a little more invasive. And there's also an atrial pacemaker, which is an implanted device to control the heart's rate and rhythm. But a lot of times athletes mainly treat it just by recognizing what triggers them and avoiding that and kind of training around it. Some of the things that can trigger it are altitude, caffeine, stress, things like that, but it's very individualized based on the athlete. The first case I looked at was an athlete named Tom James. He was a rower for Great Britain and competed in the Olympics in 2004 and won gold in 2008 and 2012. He was a really good example because he kind of fits the mold for athletes with atrial fibrillation. He has the same profile as a tall endurance athlete, and I'll go into his paroxysmal atrial fibrillation. So he was diagnosed in 2011, just before, it was about a year before the actual Olympic Games, so it was an issue. He didn't know if he was going to be selected. He didn't know if it was going to stop from making the team. But like I said, it's paroxysmal atrial fibrillation. And his complaints were mainly fatigue, rapid heart rate, and palpitations. He said he had palpitations through most of his life, but he kind of just would shrug it off. He just kind of thought that's how it was. And like athletes too tend to kind of ignore things longer than someone else just because that's kind of their mentality. But after he had a training cycle that was at altitude, and when he came back from that, the palpitations got significantly worse to the point where he sought out medical attention for it. they were using heart rate monitors during training just before he was diagnosed. And before even exercising, his heart rate jumped up to around like 200, 250 beats per minute. He also had increased fatigue. They thought it was flu at first or a virus, but after a few weeks, and it didn't improve, that's when they kind of thought it was something to be concerned about. And he was originally prescribed medication just to control the rhythm of the heart, but he mostly treats it just through recognizing the things that set him off. Like I said, it started with a training cycle where it was at altitude, so that's one of those things he has to avoid. And just generally, stress is one of the things that can trigger him, so he has to try to, especially during competition, so it doesn't come on as he's about to compete, just keep his stress levels down. And he also has to follow an individualized training program. Especially right when he was diagnosed, he couldn't really train with the team because he had to train around his body and kind of figure out what things were going to set him off. He didn't want to be training with the team and then have to pull out of it just because it kind of flared up. But like I said, it's kind of a success story showing that it doesn't have to impede your athletic performance, because he did go on in 2012, he made the team, and they ended up winning gold. The second study that I looked at was, is the risk of atrial fibrillation higher in athletes than in the general population? A systematic review and meta-analysis. I like this study because it pulled together a lot of other studies. A lot of the research on this is, and I'll go into it more in the next slide, is very similar. And this was just a study that kind of encompassed a lot of it. And it ended up using 6 eligible studies. They kind of were pretty tough about what studies they were going to incorporate, because they wanted studies that looked directly at athletes versus non-athletes. And they ended up with a total of 655 athletes from those 6 studies and 895 controls. And it showed that athletes showed atrial fibrillation at 23%, whereas the controls were 12.5%. So you can see it's almost double, so it's a significant difference. And they concluded that risk for atrial fibrillation is significantly higher in athletes than non-athletes. So going along the same lines as that, most studies done on atrial fibrillation are based off survey data, because it's a difficult study to, or a difficult topic to study experimentally. You can't really try to or attempt to induce atrial fibrillation in somebody. So they really have to judge it or base most of their data on surveys. They do a lot of single surveys, but there's also a lot of longitudinal ones where they'll survey the subjects, and then whether 5-10 years down the road they'll survey them again, just to see if it's progressed, if it's gotten worse, if they've been able to manage it, things like that. And like I said, most studies agree that it is significantly more prevalent in athletes than in non-athletes, and they don't really agree why. They propose a lot of theories. Most papers that do surveys, like the previous one had, at the end of it they'll propose a theory as to why, which has a scientific basis, but that's not really what the study is testing. And also the studies, the long-term ones, show that athletes rarely progress past paroxysmal. They'll usually, just because they maintain their level of fitness and health, it doesn't really get worse, whereas in the general population, it's more likely to progress to persistent or permanent. And one of the big topics too is whether this should disqualify athletes from competition, whether it puts them at higher risk of either developing other cardiac conditions. And most of them agree that it doesn't have to disqualify them. The main thing is, if they manage it correctly, it shouldn't have to even impede their competitive level. They should be able to maintain the same level of competition as before they were diagnosed.